Alright, so for this episode of OMT, we're going to talk about what exactly are we treating when we're looking at a structural problem, that is to say, a somatic dysfunction. Once again, my name is Dante. I'm the fourth year who has a little bit too much time on his hands. So, if we're looking at a structural pathology, that is to say, somatic dysfunction, essentially we're going to break it up into two components, that is the biomechanical and the neuroproprioceptive. Now, these two components, these two words are very detailed, very in-depth things that we can go into, but I'm saving that for a different discussion. Today I'm just going to simplify it. The biomechanical, as far as we're concerned, is essentially the hardware component of the problem. The neuroproprioceptive is essentially the software component of the problem. So by hardware I mean it's your body, so it's your bones, your muscles, your ligaments, your joints, your nervous system, so on and so forth, and how it's actually maneuvering in space. Is your bicep too tight for you to fully extend your arm? Is your nervous system so turned up right now that you're just holding, like you're in this constant fight or flight system, so on and so forth. The neuroproprioceptive, when I say software, I mean exactly that. It's your programming. So this is your gait, your posture. Where do you want to be in space? What feels good for you? What is your baseline behavior like? And the interplay between these two components is what leads to function. And when problems show up in how these two play out together, you end up with dysfunction, which is kind of what we treat. So we have things like muscle energy, HVLA, and sometimes soft tissue work in order to address the biomechanical. That's loosening the muscles, that's getting the bones and joints back where they belong. Then we have the neuroproprioceptive component, which is actually changing how your body sees itself in space. With things like counter strain and with balanced ligamentous tension, what we can do is we can actually change what your set point is, where your body wants to be, so that whatever treatments we do in the biomechanical component end up lasting more permanently than just a few minutes. So let's play out an easy scenario just to kind of give this a bit of context, because context is important. Let's say we have a right superior shear. So that's when your right innominate is higher than the other. So the biomechanical component is simply that. The innominate is higher than it's supposed to be, and we can pull it back down, whether by just actually pulling it down or other exercise things, so on and so forth. The neuroproprioceptive component would be the what got it there in the first place. What are you doing that makes that shear happen? Was it a traumatic thing? Because if it's traumatic, then that's its own thing. But if it's neuroproprioceptive, that means it's something you're doing to yourself. So do you stand with more weight on your right hip than your left, and does that feel comfortable for you? Because if that's the case, just because there's more pressure on your right side, eventually that right side is going to end up working differently than the left, and you end up with a problem. What happens is if you only treat the biomechanical, the problem comes right back, and if you only treat the neuroproprioceptive, the patient's still uncomfortable. In order to do OMT, I guess, most effectively, I would argue that you have to do a bit of both. That is, some component of muscle energy, some component of HVLA, some component of BLT and counter strain, and so on and so forth. Alright, well, that's it for this video. It's pretty straightforward. Go out and treat.